as you can see, GDP, healthcare spending as a percentage of GDP continues to rise here in Chile as it does in other countries around the world. So what I want to talk about is some implications. There are implications for how we coordinate care and how we do a better job of coordinating care in our ecosystem, in our health system. There are implications for innovation and the way we think about health in general, because a lot of it is about me as the person. A healthcare individual who has to interact with so many different systems. And again, that's not just something we see in the US or the UK, we see that everywhere. So we think about the journey of caring and coordinating care for patients as a journey. You start with basic, you share information about your patient. You start alerting, so when I end up in an emergency room, or your mother or your brother, you want to know about that. You want an alert. You want the people that care for you to know that you've actually had serious illness and somebody needs to take care of you across the care system. You then move forward and you actually want to start looking at the person's health record across the ecosystem. You want to view into what's happening, not just at the primary care, not at just at the clinic, not with the specialist, but across the continuum. You want caregivers to start messaging, and you actually want the patient to start looking at that information as well, so that they can start engaging in the health system and start to change their behavior. We also think of the Internet of Things. There are so many devices now, if we could actually harness that information and pull that together, we could really make a difference. We look at advanced care coordination, things like gaps in care, and stratifying the risk. Who are our sickest folks, and how can we do intervention? Who are the healthy ones, and actually how can we keep them healthy? And finally, we look at predictive analytics. How can I predict actually who that next person is that might be admitted to the hospital or might get have an inpatient stay? And then we need to look at the cost and the outcome. What is the value to the overall health system of the types of services we're delivering? So I want you to bear with me. This is a 5-minute video, but it talks about a program in the United Kingdom where they're starting to connect those dots and bring that information together to help patients who are at the end of life, have chronic illness and know they're very close to the end, or have cancer and what they're doing about that. So bear with me. This will take a while, but it's worth watching.
Now, to a breakthrough in helping people with one of the most profound decisions they will ever make, how and where they would like to die. Too many patients end their days in hospital when they would far rather be at home with loved ones. For the first time, a secure online system links patients with GPs, hospitals, and even paramedics answering 909 calls, so that everyone can instantly see where patients want to go and even whether they want to be resuscitated. Our health and social care correspondent, Victoria MacDonald, has this exclusive report.
Yes, quite.
2 strokes and before that brain tumours means Jane Lever has, and there is no other way of putting this, had to confront her own mortality several times.
I didn't want to be resuscitated because I thought I've already had goodness knows how many extra years. I'm meant to be dead already.
Now 78 and a doctor herself, a specialist in community medicine, Jane Lever is very clear about what she wants for her final days, and that includes not dying in hospital.
If I became unconscious, say, I might need, say, intravenous feeding with a drip. Well, that's not a normal thing to do at home. And so it's a good thing to have all that sort of stuff organised in advance.
And how Dr. Lever has organised it in advance? It's through a new online platform, Coordinate My Care, or CMC, setting out all her wishes with the help of her GP. But critically, it can also be seen by other clinicians, even paramedics.
You put significant medical background, what the preferences were, resuscitation, an emergency treatment plan, so that's what to do at 2 a.m. in the morning. Mental ill health.
And this is where CMC started, with Professor Julia Riley, who'd seen her own sister-in-law struggle to have her wishes followed as she died from cancer.
She was looked after by 2 good hospitals, a good hospice, a community service, a GP, very good GP, and yet those services run 9 to 5, which is 1/3 of the week. So when you call for help in the other 2/3 of the week, you're getting people to care for you that don't know you, have never seen you, don't even know what the diagnosis is. Why could we not just all share that information? And so when she did die, the group of us got together and we did a paper form of a care plan. And then the paper form became digital, and then the digital form connected to the urgent care services directly.
Here is a dummy account, but 50,000 real patients have now signed on to CMC. 20,000 clinicians have trained to use it. The platform was developed by InterSystems HealthShare, who have had to overcome the problem of data protection.
So for Jane, it's things that, as Peter said, are easily reversible and that can only be dealt with in hospital, like a fracture. But then if she's just become a bit more unwell, and we know that in a couple of days actually she'll turn around because she's had several of these episodes and she does get better, but it looks quite alarming to somebody who doesn't know her, then it says, don't panic, don't take her to hospital, call the GP.
A significant development is that London Ambulance Services paramedics can now see through the system immediately what the patient's problems are and what their wishes are.
We've been a paper-based system for many years now, and having to find out information. Imagine a typical scenario of being in a patient's house is accessing who their clinicians are that they've been working with. Some people have very organised files, and some people have letters scattered everywhere. And we have to be a bit of a detective to find the information.
And where it matters, at the end of life, the figures show it's working. Nationally, 47% of patients die in hospital, not all of them wanting to be there. But those with a CMC plan, it's only 19%. And overall, 78% of patients who've signed up die where they want to.
This year is the 70th anniversary of the NHS, and in many ways this exemplifies what the health service is all about. First of all, it addresses the fundamental question of what patients want, especially at the end of their lives, how they die, where they die. But it also introduces new technology to make those decisions so much easier.
Jane Lever's plan, drawn up with the full support of her husband Peter, has been adapted and added to as time has gone on. But her fundamental wishes have remained the same and are there for all to see.
Victoria MacDonald reporting.
Thank you. That's a really important story that's happening, and we'd like to see more of it. So I'm going to talk a little bit about coordination in real time. This is towards the other end of that care coordination spectrum. So Healthix is an information exchange in the city of New York. They connect 16 million patients in the greater New York City area and thousands more in the Long Island area. But what they do is they connect together hospitals, clinics, ambulatory, social services. They even connect to our criminal justice system, so our prison systems get connected. And if you think about, they are further along in their journey. So they are starting to develop predictive analytics based on all that patient information that they've brought together, and to create a way to let providers know when something has actually happened or might happen with their patient. So there have been 2.5 million clinical event notifications that have gone to providers caring for a panel of patients so that they know there's something they need to do and intervene. And what's amazing is Mount Sinai Hospital, which is one large academic medical center, actually saw that when they used to just call patients after they were discharged from a hospital, the patient would say, why are you calling me? You know, I just got discharged. What they find is when they actually get the alerts, call the patient or call their family member and start to talk to them before things progress, their engagement with the patients have gone from 15% to 85%, and they're able to have that conversation with the patients that are very patient-centric, that allow them to actually intervene and improve the care. So one of the things with having a predictive risk model, though, is knowing where to focus your energy. You can't do all things for all patients. Most providers have 3,000 to 4,000 patients that they're trying to take care of at the same time. So what they have been doing is using these risk models to focus on those folks, those patients that need intervention now, so that they can get ahead of the curve before they get chronically ill, before they get admitted to the hospital. And so they create these cohorts of risk-stratified patients, and then they allow them to know when to intervene, and they have what we call care managers that actually do that and work with the patients to help them stay healthier. There's another implication we see for our digital health world, and that's that we see that there are multiple connections. In other words, as a patient, I don't seek care in one location. There are so many different sources of information about me, and they're not just in the healthcare system. They're in my home, they're in my community, they're with my family. There's all kinds of information about me and my health that a hospital will never know, but they probably should. We see that care needs to be coordinated because it's a multi-provider world, that it's a multi-patient world, so it's about me, but it's also about providers managing cohorts of patients. And finally, it's multi-time. What happens to you today will impact what happens to you in the future. You need to look at the context and the history of how you're viewing an individual patient. And so what we have done is we have a unified health record that is able to create those connections using an HL7 standard called FHIR, which is specific for the healthcare world. We have interoperability and the ability to aggregate that. There's coordination that we provide, alignment, engagement, communication, both within our provider community through a community-based portal, but also with our members and patients. Understanding the analytics, the measurement, and the discovering are really important. You can't change healthcare until you can measure it, until it's connected. And finally, having a perspective on that care, that multi-time, the care planning. We saw that with CHC. Chronic care management and the trending. Are my patients getting healthier? Are they meeting the quality measures that I've set as a benchmark? All of those need to be done over time. So another one of our customers is the Lincolnshire Health and Care System. They're a very rural area in England. They're highly underserved. They have a huge percentage of their population that's over the age of 75. They have very few medical services. So if you think about the remote areas here in Chile, where that's the case, that's what it's like there. High level of chronic disease, poor infrastructure, poor telecommunications. So what they did is they brought together the information from 13 health and social care organizations across that region, and they unified that into one aggregated record. And they brought in data from all kinds of systems. Legacy systems, emerging standards, proprietary formats. The information out there was in so many formats, but they had to bring it all together and create one view. So if you think about the patient being at the center of all this, that's how the information is organized. And again, they were able to bring that into a unified view that sits on a set of standards that are able to see a longitudinal record and see a patient-centered record. So they have an integrated provider portal, and then they have a patient view of it. So both the patients and the providers have a view into that same set of information. The other implication for what we're doing with all this digital data is innovation. We are not going to change healthcare unless we change the way we deliver healthcare. Somebody always says the definition of insanity is doing the same thing over and over and expecting different results. Unless we fundamentally change healthcare and the way healthcare is delivered in Chile, in the United Kingdom, in the United States, globally, we are not going to stop the rise in cost and improve the outcomes for our patients. And that's you and me. That's not just another person. We are all, at one point in our journey, a patient. So let's think about that. Part of what we want to do is use all this great information that we're able to bring together and harness that not just for care delivery, which is incredibly important, but for innovation and future thinking and scale and fluidity. But we have to balance. There's the care we're delivering today in our health system, in our clinics, in our hospitals. And those are things we don't want to disrupt, because you don't want to disrupt that care process. You want to take really good care of the patient you're seeing today. So we need that stability. Can be used and harnessed alongside those operational systems to start doing innovation. So the need for continuous rapid innovation using web services, mobile apps, the Internet of Things, precision medicine, big data, all of those are great possibilities, and we want the infrastructure for both. So my last story is about Providence St. Joseph Healthcare. They are a very and in the Northwest. So they have 9 million patients across their entire health system. They have 300 different data sources they're actually bringing together to create their record. There are 2,500 providers that are contributing information, and of those, there are participating entries, and there are 40 to make sure that the clinicians can do what they need to do. But then they have a unified health record that they're using alongside that, and that's their innovation platform. And they're bringing in information from primary care, from specialists, from what we call post-acute care, which is our long-term care, our rehabilitation hospitals, our payers, and social services organizations. So they are bringing all this rich data together. And in the US, we have something called the Clinically Integrated Network, which is a private payer network that provides services only using providers that are part of that network. So again, when they went to look to see who in their clinically integrated network were participating, the majority of them were already participating. And so I only have a few minutes or a few seconds, so what I'm going to say is they are using that information in the clinical viewer that providers look at, but it's their launching point for innovation. And they've created a product roadmap, and they've built on that. So when providers go and look at that unified record, they actually say, but what if? But what if? But what if? And the nice thing is that the folks at Providence St. Joe listen to that what if and start to pilot and test innovative ways of looking at that information. So they're doing notifications to their care managers. They're looking at quality measures for diabetes. They're looking at clinical pathways. How do I follow the right pathway? And they're even looking at pre-op things. What do I do to prepare a patient before they actually walk into a hospital for a surgical intervention? So I think that, as you can see, the future is challenging, but I think the future is there, and the future is now. And we really need to use this digital information from all the places we can get it to focus it and transfer our care processes. So again, thank you all very much.